I first crossed paths. That was a 3-year training program. From that point, I went to the Cleveland Clinic and did an additional 3 years in cardiology. So I'm a board-certified cardiologist. And then following that, I did an additional 2 years in electrophysiology, which is also at the Cleveland Clinic, which is specializing in electrical problems of the heart.
Yeah, so I did 3 at Vanderbilt, 3 years of internal medicine, then I stayed at Vanderbilt and did 3 more years of general cardiology, and then 1 more year of electrophysiology. Well, sort of a year and a half combined, but yeah, 4 more years of cardiology at Vanderbilt.
I would say it's about, from the point you graduate college, it's about 12 years of training to get to the point where you're actually working.
And you're working a lot, I know.
Yeah.
Let's go to another piece of video that we have to continue looking at this surgery and the progression of how you treated this particular patient. And as we do, I want to ask you this. How long after the ablation do you have to wait to return to normal activity? A question from one of our internet viewers. We talked about it a little bit a minute ago.
I tell people about a week. About a week. What we're looking at here, and this points to the question that an earlier viewer had about the esophageal injury. And what I was just showing at that point was the esophageal temperature. And so we do know that there are rare cases of esophageal injury that happen because if we can cut to the model, I can show you that the esophagus actually courses on the back side of the heart. And this is the left atrium. So this area is the area we're ablating, and then this is the location of the esophagus. So you can see they're in very close proximity to each other. So what I was showing there was the temperature probe that we use in order to determine we're not having esophageal heating.
Right, right. One more thing that you monitor as you go through it.
Sure.
You might want to return to the video and let you
and at this point, this is just basically showing the manipulation of the catheters. We have 4 catheters inside the heart. All of these catheters are then placed at about the knee level of the patient. And by using either clockwise torque or counterclockwise torque, we're able to manipulate these catheters. And as we mentioned before, this image we're looking at it's a fluoroscopy image, and it's in 2 dimensions. So there's no real way for me to tell whether or not that catheter is in front of the other catheter or behind the other catheter.
Okay.
And so we used the 3-dimensional technology in order to give us both sort of an X, Y, and Z axis to know exactly where we are. And here we're going back, we're showing the electrograms from the pulmonary veins. And you could see in the electrograms I'm pointing to, there's some potentials, what we call pulmonary vein potentials, still there, where the ones on the bottom don't quite have as much activity.
Yes.
So what I'm going to do at this point is I'm going to go back to that area where I'm pointing to now on the pulmonary vein and ablate that area.
Okay. Let's take another question as we look at this. Is your ablation the box mini-maze technique, and are you using J&J thermocool catheter? This sounds like someone in the medical profession, doesn't it?
Yeah, we are using the thermocool catheter. It is not the box mini-maze technique. I believe that's more of a surgical technique for cardiovascular surgeons.
Like an open?
Correct, right. That's done when they do mitral valve repairs or even bypass surgery. They can go in and do a maze procedure. This is a pulmonary vein isolation. There's a lot of different names for it, but essentially it's a pulmonary vein isolation for atrial fibrillation.
Yeah. And the thermocool was the irrigated tip catheter that I showed with that spray.
Exactly.
That catheter is certainly, as I said, has almost become standard of care in the treatment of atrial fibrillation.
Are you wearing lead, doctor?
I am wearing lead, yeah. And we do use X-ray fluoroscopy. And so, although if you're a patient who's there, for a couple of cases, there's no harm. But as a physician who's standing in front of that X-ray, we need to make sure.
Protection.
Yeah.
Sure. Exactly. Here's another question that is interesting to me. How long do the holes that you make through the septum stay open, and are there any problems associated with those?
Yeah, we've actually looked at this, and we've studied, and we've done follow-up echoes to look to see whether these holes we create go away. And in most cases, they do seal up on their own. As a matter of fact, there's often times that if we have to go back and do a second of ablation, that hole is often closed. A lot of times we wish it was open. But it's usually not. It's usually scarred down. And we see no long-term problems with the holes that are created.
Okay. Let's talk a little bit about the risk involved just during this procedure, risk of blood clot, risk of stroke.
That's really the main one that people have to know about is stroke risk, and it's around a 1% risk. The other main ones that we talked about, esophageal perforation, that has gone down as a risk just because we're monitoring a lot more carefully. 5 years ago, we didn't know as much, didn't monitor as much, it was a little higher. The other risks are bleeding from the access points. You can actually, by ablating, you can irritate the heart, and you can get an effusion, which is a fluid around the heart. That's another complication. Those are really the main ones that we talk about with patients and that patients need to know before they undergo this kind of procedure.
Blood thinners during the procedure?
Absolutely, yeah. We thin patients' blood with heparin. Before the procedure, they're always on Coumadin. A lot of times we'll do a procedure called a transesophageal echocardiogram that looks and makes sure there's no blood clots in the heart the day of the procedure. So there's a lot of safety precautions that go into any of these procedures.
Will they continue on heparin or Coumadin for a certain amount of time after the surgery?
Yes. After the procedure, we use both aspirin as well as Coumadin for our patients. The big complication, as Dr. Smith mentioned, is stroke, and it's close to 1%. If you look in published trials, it's 0.8%. Now, most of those events are transient events, meaning that following the event, the patient does not have long-term problems. But there are certainly a small percentage of those people, of that 1%, that do have long-term problems, meaning can't walk or can't talk. And so that's important to know. And if you're a patient undergoing this procedure, that's obviously your biggest and our biggest fear.
Absolutely. Sure. Let's talk a little bit about what we're seeing here in the surgery again. The imagery, which is just amazing to me, the 3D manipulation is just...
Yeah. Right.
Here Dr. Savilla's ablation catheter here is the red moving target there, and he's manipulating inside the heart and using that 3D map to guide himself and placing his catheter around those pulmonary veins. And then here we're back to a fluoroscopic image, or the moving picture of an X-ray, and we just use these we change from each one and use fluoroscopy, then we'll go back and use the 3D mapping, and we really use them in conjunction to guide us with where we are.
And what you can see here is if you would vision that we're looking at the right inferior pulmonary vein. This is the echo image of the right inferior pulmonary vein. So I have my lasso catheter positioned there, so I know I'm ablating on the outside of that vein. And then once I know that, I'm going to go back to either my three-dimensional image that we saw early, or the fluoroscopy image. And what we're going to do is we're going to create a circular lesion around this lasso catheter. So you can see now my ablation catheter is at 3 o'clock, and then we'll usually burn for around 20 seconds. This film is sort of sped up a little bit, so it'll look like I'm moving quicker, but every 20 seconds I will then drop my catheter down, and now I'm sort of ablating around 4 o'clock. And then we'll slowly, usually my next lesion will be 5 or 6 o'clock on that clock face. And then what that does is create that circular area of scar tissue around the pulmonary vein.
Wow. Let's take a question while we're looking at the fluoroscopy. How does the tricuspid valve work properly during total atrial fibrillation?
Tricuspid valve is on the right side of the heart. The mitral valve is on the left side of the heart. So what we deal with here, and we try to stay out of the way of, is the mitral valve. But the valves still work despite the atrial fibrillation. They close and open properly. And symptoms are really generated by that abnormal, irregular response that the ventricle has, and the ventricle is the pumping chamber of the heart, and not necessarily by any valve dysfunction. So the valves don't play as much of a role in atrial fibrillation.
Another person writes, what kind of energy is used to ablate? Do you prefer one kind over another?
Yeah. There's several different type of energies that people use. I would say the most common we use is something called radiofrequency energy, and that's what we're using in this case. And that's, again, electrical energy that's turned into heat, and we heat up the tissue. There's another type of energy called cryo, or cooling, freezing. That's another type of energy that we don't use quite as much anymore for atrial fibrillation. We were using it more for atrial flutter.